Igor Weinberg, good morning. For you, it's it's lunchtime, more or less.
Yeah, good afternoon for you too. Thank you so much for meeting with me at this odd hour.
My pleasure. And Igor, can you introduce yourself? You are one of the most relevant experts in the field of understanding and mostly treating narcissistic personality disorder. Can you say something about your work? Where do you work? What is your background?
I'm a clinical psychologist. I work at McLean Hospital, an outpatient clinic in the center that specializes in treatment of personality disorders. So that's my clinical work, and I, write about treatment of personality disorders. In the last decade, it's primarily narcissistic
Yeah.
personality disorder. Yeah.
Well,
Yeah.
and how prevalent is narcissistic personality disorders?
That's a very good question. I mean, we today we could probably say it's between 1% and 2%. That's the estimate. There are some estimates that could say that it could be even 6 or 7%. However, those estimates were sort of corrected when researchers took into account the level of dysfunction of the patient. So it turns out that a lot of people might have the traits without necessarily associated distress or dysfunction. And so that's in general population.
Oh, yeah.
That's in general population. When we think about clinical population, it could be easily between 8.5% in outpatient practices to almost 20% in outpatient practices. It really varies. So it could be quite prevalent.
Yeah. That brings two further questions. Why there is no randomized control trial on treating narcissistic personality disorder, given how prevalent it is, how important it is, and how often do we see it in our clinical practice?
It's a very good question. I think there might be multiple reasons for this difficulty to conduct randomized controlled trials with patients with narcissistic personality disorder. One of them is that not many people are invested in this area professionally because the disorder itself has a sort of a bad reputation, quote unquote, of not being very treatable. So when people are saying, what do I want to invest my career in? Treatment of depressed patients that seem to be treatable and people that seem to not be very treatable, I think a lot of people suggest that maybe they should go in the direction of some more treatable disorders. But I don't really agree with this. I feel like it's a little bit like saying we don't want to treat cancer because there's such a high morbidity with this. And so that would be my approach. So that would be one reason. So not many people are interested. Another reason has to do with the very high dropout rate that historically people with NPD were reported to drop out of treatment with a very high frequency. Up to 2/3 of the patients are maybe dropping out of treatment, so not many trials would be feasible. Well, that would require very large samples, and the results may not be representative. So that could be another reason. Like a third reason may have to do with patients themselves that may not really like the idea of being randomly assigned to treatment versus something else. And specifically, patients with narcissistic personality who really want to feel that they're getting what they deserve and what they're entitled for. They might feel that how come somebody else is going to randomly assign me to something? So the idea that something is not under their control also in itself may feel not very agreeable. Yeah. So that's going to be some of the reasons.
Those answer makes a lot of sense. So I would have an answer because maybe I didn't see it this way, but it makes sense. And so maybe it wouldn't be good to run a randomized control trial against treatment as usual, but one can design a randomized control trial pitting against each other two active conditions. So both are okay, and narcissistic patients would be glad anyway. You are in two of the best treatments for your disorder, so you'll get what you deserve. Yeah.
unless they feel that the grass is greener in the other arm of the treatment, and then
That is still possible. That is still possible.
we don't know. It would be interesting to see how that actually happens, if they can tolerate this. I suspect that actually may be better tolerated than I'm saying this, and it actually
Yes,
maybe
I know.
comes
We'll
down to
come into that area. And
yeah, yeah.
they have a bad reputation, and it's strange because there is some common ground knowledge which is completely false, by the way, which narcissistic people don't go to therapy. They make their relatives suffer, their wives, their spouses, but they never go to treatment. It is completely false. They go to treatment because they suffer.
Yeah, there is sufficient research to show that both could be true. I mean, people could make their spouses and significant others suffer, but we also have research that shows that people with pathological narcissism and NPD suffer themselves and
Yeah.
experience very intense and very painful emotions. And that in itself may not be related to willingness or ability to be in treatment, but they definitely suffer and may actually have
Yeah.
motivation
Yeah. Yeah.
to be in treatment. So that's not,
And
we
what
already
is
passed
your
that point. Yeah.
Yeah, 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 absolutely. And what is your personal stance? Do you think they can be treated? Is there room for optimism? I think we have room for optimism, but what do you think?
My personal stance is based on my personal clinical experience of clinical colleagues that I know of, and also my read of the literature. And I see that, some patients with narcissistic pathology can change, and they can change quite a bit. Some could be difficult to
Yeah,
engage in treatment, but that's probably true about any disorder. So it's maybe the proportions could be slightly different. But overall, I think that people with pathological narcissism can use therapy productively and can really change in a meaningful way.
yes, I totally agree. And of course, we don't have data, but I think that if some good design trial with tailored therapies would be conducted, probably the dropout rates would be much less than two-thirds.
Mhm. It's probably going to be much less. I'm about to publish a report where we collected cases of successful, or what we call successful psychotherapists, people with narcissistic pathology that changed in a significant way, and both
Mhm.
symptomatically but also functionally.
Yeah.
They all changed in treatment. Of course, there's no comparison group, but it's a compelling case to see that people in treatment could really change, and we could observe that some of the changes were related to treatment processes.
Yeah. And according to your experience, uh, which is the hardest aspect of narcissistic patients to change?
This is a very interesting question. I think it has to do um, with essentially internal difficulty to ultimately develop better relationship with themselves.
Hmm.
So we ultimately think about people with narcissistic pathology as people that love themselves too much, but in reality, what's the underlying feature that is one of the core features is how much they dislike themselves. And
Yeah,
that
absolutely.
feature of really ultimately not being able to love themselves with a really emotional component, that's the feature that persists, and that really is responsible for the black and white thinking in the same area and
Mhm.
difficulty accepting all parts of themselves. And other features can change, including interpersonal features that actually many times are pathognomonic and distinguish pathological narcissism from some other conditions. They can actually change over time, but that internal feature of not liking themselves and essentially not being able to accept themselves for who they are
Mhm.
is quite persistent.
What I found in my experience, I've seen many men with narcissistic personality disorders. Some of them had obsessive compulsive personality features, so highly perfectionistic and demanding, but more functioning. Some of them were covert narcissists, some of them were grandiose, but I've seen them become excellent parents, excellent fathers in particular. They became very committed to their kids, very emotionally sensitive. Does this match your experience? Some of them.
I could say that I can say that in different areas of functioning, people could function really differently. People could be very competitive and aggressive when it comes to their professional lives, for instance, and then it
Hmm.
could be translated into kind of a different experience
Hmm.
with their kids. A lot of times, what I observe is that people repeat their own childhoods in reverse. So essentially, they become either they become very similar to how their own parents were with them, or
Hmm.
they try to correct it if they have some awareness of this, and
Hmm.
sometimes they
Yeah.
want to become very, very different.
Hmm.
So I would say that if they have good parenting, at least they had at least one parent that was able to love them,
Yeah. Makes sense.
maybe they could become good parents themselves. So I don't think it's prohibitive. And I think also we have to remember people could really function differently in different areas.
Yeah. Coming back to to self-view, to the difficulty to love themselves. Um, you repeatedly pointed out in your papers, in your beautiful papers with Elsa Roninstam, about clinicians being mindful of not challenging uh, self-despise, high, extreme self-criticism. And
Yeah.
this is something that clinicians don't really frequently know. Can you tell more about this?
Yeah, this is an idea that goes back to contributions of other people, including Tony Chris and Stephen Cooper. Both of them wrote papers about this. But this is a more general idea that the idea is that we're looking at the function of self-criticism and self-hate rather than
Self-hate.
directly challenging this. I mean, a lot of clinicians probably had that experience of sitting with a self-hating patient and giving all the reasons why they should love themselves, and then it's usually falling flat. And that's really not a experience that's usually not a technique that is super helpful, and we all did something like that. A more helpful approach is to invite the patient to kind of inquire about the function of that self-hatred. If there is a function in terms of what they may be getting out of that process of hating themselves. Sometimes patients do it because it actually elevates their self-esteem. They feel like if they criticize themselves so harshly, it actually means that they're holding themselves to a very high standard.
Yeah,
And
absolutely.
paradoxically, it elevates their self-esteem. A lot of patients feel like this.
Yeah, makes
For other
sense.
patients, it becomes an opportunity to avoid some painful experiences. And so it could have multiple functions worthwhile exploring it and showing the patient that it's only one way in which they accomplish a certain goal, not the ultimate way in which they can
Yeah.
accomplish that goal. Yeah.
Yeah. Well, can we say that sometimes they criticize themselves very harshly because it's like they're still striving to achieve something, but
Yes.
if they accept they just that it's normal they failed something, they have to we discussed it in our commentary to the issue of the Journal of Clinical Psychology in session about treating narcissism. You focus a bit more on grieving, I focused a bit more on facing negative emotions, but when they are still in the process of self-hating, they don't have to face loss. Makes
They
sense?
don't, no. It could protect them from a sense of loss and the need to give something up. So ultimately, it preserves that sense that grandiosity is still possible despite disappointments, despite failures, etc. So it really has a protective value, and helping the patient see that that's really the function, and that could really highlight the dilemma that they're facing here.
Yeah.
Yeah.
And speaking about criticism, I tell you a personal vignette. It was I treated for some years a woman, a lawyer. It was very
Mhm.
nice actually, and she suffered from grandiose NPD. And I love lawyers, I have to say, but as many lawyers do, she just loved making other people feel bad. She loved to argue with the goal of making the others feel an idiot, more or less. And
Mhm.
kind of she did it with me every beginning of the session. Okay, she started with harsh criticism with irony. That was very important. And I retorted systematically. So basically, we started the 5 minutes of our session insulting each other, but that was great. Okay. And I had difficulties once. And because, I write book in Italian, not just scientific, but kind of a mixture of, divulgative, scientific, and narrative. Okay. And I care a lot about them. And she read them, and she always criticized my style, always. And she said, maybe you should find a publisher who check the proof more carefully. That was something she said once. And in another situation, she she gave me as a gift a book by the American novelist Kent Haruf. I never read him. And she said, maybe you learned something. And I have to say that I did, because he is a great writer. I bought his other books. But when she gave me this gift, maybe you learn from him. It was a bit difficult to not send her to hell. And but I did, and we managed, and we discussed about the role of self-criticism and others
Yeah. Yeah.
referred criticism. Do you have episodes where you had difficulties facing criticism or spite from some patient with narcissism?
Yeah, this is a very good example. I can think about a couple of examples of people presenting very similarly. And um, I had a patient that told me at some point that there's nothing really meaningful that I can tell her or tell them about themselves, because in reality they already thought about everything themselves. And if there's something that I have to say that they never thought about, it must be wrong. So that was really a no-win situation, because I cannot add anything to their self-awareness. But it also seems like whenever I say something new, or so to speak, new, what I thought was new, they would discard it very quickly. So that's sort of a pattern of dismissiveness that is
Yeah, of
so
course.
prototypical. And it's very injurious to our own narcissism as therapists. We also have a healthy narcissism as therapists. We want to help people, we want to be useful, we want to be meaningful to other people. And then we don't like it when it's not being accepted or welcomed by patients. And so it's a very painful experience. And one of the reasons that patients with NPD don't sort of become welcomed in psychotherapy practices, and so difficult to sit with them. And that's another reason that being able to tolerate feelings around this and developing some own tolerance of our own feelings of disappointment and failure and rejection is so critical, actually, when we treat patients with pathological narcissism. The way you describe it, for instance, it almost sounded maybe there was something playful about that interaction. The two
Yeah,
of you were
it was.
engaging in this sort of a playful interaction where you get rejected and she has to denigrate everything you're saying. But in reality, two of you could sort of play along and kind of move on.
Exactly.
And it's hard to not think about those details, because it may seem like a relatively minor aspect of this. But in reality, patients observe it sometimes and internalize our own ability to respond and learn from ability that actually it is possible to receive criticism and it's not end of the conversation. It's possible to move on.
Yeah,
And
exactly,
it would
exactly,
be interesting to think about if she was replaying in projection, essentially with you, sort of to speak,
exactly.
something related to her own dynamics. And actually, it was a constructive reaction. And I would really distinguish here between interactions that feel sort of like a really deadening interaction, that there's nothing playful about them, and interaction that could be much more playful, that actually there's something that the patient is working through in this particular way.
Yeah, you make me think about a very difficult to deal with pattern that I often see when I supervise colleagues. That is a mixture of colleague very high in the caregiving motive
Yeah.
and patients who are both spiteful and bitter. This is a difficult match
Yes.
because my colleagues try to help them. They want to help them. They feel responsible, and what they get in response is this combination of you not helping and with
Yeah.
a very you know, overmodulated anger and bitterness. And this is difficult to tolerate for many clinicians.
Yeah, this is why we could talk about a different configurations of match between different types of narcissism and different conflicts that show up in the relationship and personalities and conflicts that we have as therapists. And certain type of configurations can sort of lock together and produce this very difficult interactions, and some of them could produce much more productive interactions. For instance, with what you're identifying, people that are very eager to help, it may be difficult to sit with narcissistic patients because sometimes you will sit with them and everything will be denigrated and devalued, and ultimately it will be difficult to be in that position. I was told once by one of my supervisors that help in our field sometimes is not an active verb. Sometimes help will help more by sitting there and being there
Yeah.
rather than actually trying to do something. And in those moments, it's good to remember it that we don't always have to do something. Being there is an important function in itself. And this is really what allows patients to articulate this very important conflict where they have to reject everything and everything and everything. And at some point, we might be able to come back to them and say, what do you think it's about that you have to reject it? What is that about? And
Yeah.
sometimes it's about being in a very powerful position because now they can reject everything.
Of
And
course, of
who,
course.
yeah,
Yes, and then what I advise to my colleagues is say, just disclose you feel powerless.
yeah,
I would like to help you, but it looks like I can't do anything. What shall we do from now? And
yeah.
and this often helps.
That's brilliant. That's a great way to intervene too. Yeah,
That's great,
yeah,
Igor.
yeah,
I
yeah.
didn't plan it, but consider that we want to keep this conversation brief in order to people just enjoy it
Right.
and don't have to say, "Oh, this video lasts for 1 hour is too much." What about ending it with a kind of play? Okay, I will say two area of treatment that I think they are very relevant to treating narcissism, and you answer with two principles you think are fundamental.
Okay, that sounds good.
Okay,
Let's do that.
I go first.
Let's do that.
Yeah. The first is focusing on promoting agency on goals that are not about sustaining grandiosity. That is just, relearn to live, enjoy, relax, do something because it's just makes sense, also at a sensorial level. What do you think?
I think those are two great principles. The one of them is promoting agency, and another one is focusing on areas that are or goals that are not related directly to grandiosity.
Mm.
First of
Okay, so
all,
I
is
used already. I used
use
two.
two,
I
use
was
two.
considering one, so you can have three.
But I love it. I mean, I could talk about those two. That actually tells you that those principles can be combined really
Mm.
nicely. So the importance of identifying goals is very hard to overstate because this is, sometimes it makes a distinction between treatments that progress or could progress or that they stall from the beginning because there are no goals, and it also helps both patients and therapists check their progress. But it's important that those goals are realistic. If the patient wants to become the best possible violin player in the world, that's not a real goal that we can really help with. It's also not exactly what we do. Um, so it has to be realistic. When it comes to agency, it's really important to help people move in the direction that makes sense to them, and also with a sense of ownership of that process.
Absolutely.
And that's really the sense of agency, that there is a sense of movement within the treatment, and also the sense of ownership. And sometimes we help doing this with a very simple intervention of helping people identify what their contribution to progress or
Hmm.
problems, it could go either way, or sometimes by even behavioral assignments, asking people to take an active role in for example, taking on a job or joining some type of a company and volunteering somewhere and
Yeah.
taking a social role there. So those are interesting principles. So So
Okay,
maybe
actually, you stole my second principle, which is behavioral homework.
that.
But
They intersect. Yeah, they definitely intersect. Okay.
absolutely, absolutely. So the ball is in your court. And what is one or two principles that you think are fundamental?
Well, let's think about it by focusing on the relationship and addressing, for example, relationship in terms of addressing the fragility of the alliance by developing treatment contracts, for instance. That would
Mhm.
be first principle. And a second principle is
Can you give an example about this kind of contract? Just
yeah. Yeah, I think the one example that comes to mind is that has to do with this issue that we talked about earlier, that a lot of patients with NPD drop out of treatment. And that comes up when you have a patient that says that they really looking for a new therapist because they dropped out of many other therapists because they
Mhm.
didn't feel very helped. And this would be the time to actually ask them a few questions about what was the process of stopping previous treatment and then asking them to stay in treatment in the future, because essentially you might want to even predict that it might happen that they feel again that the treatment is not helping and this is futile and maybe they would like to leave. And this actually would be an opportunity for them to stay in treatment, to see what it's all about and work it through. It especially is helpful if you can point it out to patients if it's related, for instance, to their personal relationships. If it's a patient that tends to drop out of relationships in general, they tend to withdraw from important connections, or they just withdraw from instances when they feel rejected or disappointed in general. It doesn't have to be relational. So those become an opportunity. And so with patients like this, one of the interventions would be develop an agreement, which does not have to be written,
Mhm. Yeah,
which could be what I refer to as contract,
yeah,
that if they feel like dropping out of treatment, that it would be a good idea to work it through and continue treatment nevertheless.
yeah. Would we name the process you so clearly described a specific and quite sensitive kind of what is called meta communication, that is
Yeah,
communicating about the therapy relationship?
yeah, you could say that. Yeah,
Yeah.
yeah,
Because I think it's very important for narcissism. I totally agree. It's important. So whatever happens between the two of us is let's talk. Let's
yeah,
talk. So it won't control us, but it's the object of our conversation.
yeah, yeah.
Okay. And you have another principle, I think, that you can speak if you
Let's
want.
throw it. Let's throw it. Like another principle is that not all type of a changes happen. Not all changes happen within a treatment or because of the treatment, and some of the changes happen because patients learn from their life experiences.
Mm-hmm. Oh yeah, probably this is the thing that I just disagreed a bit, very marginally, by the way, when we wrote our commentary,
Yeah,
because I think this needs to be processed through therapy. Things happen,
sure.
but
Yeah,
then, of course, as a therapist, you still have an active role in transforming in something that has new meaning. What would you say?
for sure. I agree that therapy sometimes could really help people process the life events
Mhm.
that are happening with them. But I also think that some of the life events could be very transformative in themselves.
Yeah.
And sometimes, especially with patients with pathological narcissism, we can see that they can process things very kind of privately and not necessarily bring it into therapy and then report it back to the therapist like that they were going through a certain process and that really changed. There was a certain change that occurred. Um, and we could talk about that this may be a specific style which some of the patients process things, that they're more private about this. But it does happen. It's just something that does happen.
Mhm.
And it also takes off some of the responsibility from the therapist to say that everything has to be talked about because certain things patients prefer to process more privately like that.
No, makes sense. No, I never, I didn't see it this way, but it makes sense.
Yeah,
Well, Igor,
yeah,
again, not plan, but finished with a small game. Given that as our ethics prescribes, we can diagnose real persons, okay, be them politicians, whatever, but we can diagnose fictional characters, okay. So what would be your favorite narcissist in television, movies? Because I have a name, and I would
Um,
name Harvey Specter from Suits, from the TV series Suits, which is beautiful. He's a lawyer, by
I
the way.
should I should check it out. I think there are a number of characters in the movies that appear like that. I usually recommend the movie Vanilla Sky.
That was great. I can't remember
That
the main character, but I
that
will see it
uh,
again.
that was a sort of it's actually a remake of it's a sort of I'm familiar with the American version, and then I discovered that there's an original
Mhm.
Spanish version. And so it's a good portrayal of a decompensation and a narcissism, that what it
Beautiful,
looks
beautiful.
like. And because it may not seem like this at the beginning, but then it suddenly you can see all those reactions, and it's very educational to kind of observe that.
No, that's great. So
Yeah.
basically, our take-home message is read the Journal of Clinical Psychology issue on narcissism that you and I edited. And shall we spoiler your next work, or is
Maybe
it
it's
too?
a little too early. Like maybe it's too
Okay,
early. Okay.
there's something in the air. We don't say anything, but for the moment, let's
Yeah.
read the papers that Igor
Yeah.
wrote, and the issue that we co-edited, and also the paper we wrote together, and then watch Vanilla Sky and Suits in order to learn how narcissistic personality disorder is.
That would be a great idea. It was a great collaboration to write that, to collaborate on editing this journal. I have to say this. It was a very good process. Yeah.
Same with me. Igor, thank you. It was a very nice conversation. I think the readers and people who will watch the video, I hope they will enjoy, and thank you so much.
Thank you so much for doing this, and thank you so much for organizing it.
Yes. Now